Friends, I will start off with a disclaimer that my worst case scenario in the context of a biometric error has not been my field of expertise for quite some time now. In fact, how can it be today when cataract surgery is a refractive procedure and the emphasis is on hitting the bullseye in all our patients, offering them a reduced spectacle dependence. So majority of the poster patients are very close to the refractive target with minimal prediction error. However, I have been able to pull out an old case who continues to visit me till this year. And that is my refractive surprise for the year 2021. Was I audible?
Yes, we can
Okay.
hear you well.
Okay. So this is the story of a 76-year-old male patient who is an IFIS candidate because of his treatment for BPH and primary open-angle glaucoma, asking for cataract surgery in his left eye, which has a grade 4 nuclear sclerosis and 6/6 vision. The fellow eye was already pseudophakic with a vision of 6/6, -1 sphere and -1 cylinder. So the cataract surgery went off uneventfully, and I implanted a Tecnis acrylic 3-piece intraocular lens in the capsular bag. The post-op refraction was 6/6 at N6. However, there was a refractive surprise of -5.5 diopter sphere and -1.5 diopter cylinder with a spherical equivalent of -6.25 diopter. So he was having diplopia because of the anisoconia due to the full correction. So we undercorrected him. He was not very happy. However, his post-operative pressure, intraocular pressure was well controlled. And so we had to do some active intervention for him. So as part of treatment of refractive surprise, there are three options basically: laser vision correction, piggyback intraocular lens, and intraocular lens exchange. Now, laser vision correction is best except in cases of high sphere, and we are dealing with a high sphere, high refractive surprise, so that is ruled out. Intraocular lens exchange is one of the options, but it includes a lot of intraocular manipulations, and that may be associated with the intraoperative complications with posterior capsular and vitreous disturbance. There could still be a risk of incorrect intraocular lens power. A proper conduct of this technique, IOL exchange, requires a lot of instrumentation. So I decided to use a piggyback lens for this particular patient because piggyback lens offers certain advantages. It is better. It offers better patient satisfaction than corrective contact lens or spectacles, which do not work out in our patient. It avoids induced aberration and other risks associated with LASIK or PRK, and there is a less risk of incorrect IOL power and all the complications which I have enumerated, which may be associated with IOL exchange. So I decided to go for a Rayner Salcoflex lens. This lens is a wonderful design, basically a 6.5 millimeter optic size, 14 millimeter overall length, undulating haptic. It is a meniscus design, rounded edge, so it sits very well, comfortably in the ciliary sulcus. So this was my plan, and this is available in power range from -10 to +10 diopter. So I calculated the Salcoflex power for this patient using the ray trace software of the Rayner online calculator, and it came to about -8 diopters. So I communicated that to the patient, and the patient was not willing for surgery immediately. So just in case, if you don't want to use a Salcoflex lens, there are other options, and you can use the Barrett RX formula, freely available at the APS-CADS website, AS-CADS website. This formula can handle IOL exchange between two different IOL modules. Then, of course, we have the refractive versions formula from Warden Hill's website. And for piggyback lens, if you don't want the Salcoflex, then you can apply a simple rule of thumb, provided the postoperative emmetropy is within ±7 diopters and you are desiring a refractive target of plano. So if you have a hypermetropic surprise, the piggyback power can be determined by multiplying the spherical equivalent by a factor of 1.5. And for a myopic surprise, it is obtained by multiplying the spherical equivalent by a factor of 1.3. Refractive versions formulas are also there on Warren Hill's website, free. So now this patient returned for surgery 17 months after the initial surgery. And it was a scarred corneal incision. So I went for a fresh scleral tunnel. manipulations are required within the anterior chamber. So it is important that you protect the corneal endothelium with a good quality dispersive OVD. The lens is going into the sulcus. So if there is any posterior synechiae, that has to be lysed. I do not perform peripheral iridectomy, but I know some surgeons who do peripheral iridectomy for these cases. And OVD removal has to be meticulous because this is a glaucoma patient, and I do not want any postoperative intraocular pressure spike. So a piggyback lens requires a primary lens which is quite healthy for the lens to sit on its back. This lens was somewhat, the primary lens was little decentered because of capsular back contracture, but it has been there for 17 months. So I decided that, it's quite a steady support that the sulcoplex lens is going to have. And it was very well centered, as you see here. And this is the post-op picture. Till this year, the patient is doing extremely well as far as his vision is concerned, with a little bit of pigment dispersion that you see here. So basically, using a piggyback lens, I have avoided most of the complications that we get with IOL exchange. However, we have to keep in mind and be alert to the possibility of inflammation, pigment dispersion, or ocular hypertension in the long run, which has not happened in our patient. So what went wrong? Why the refractive surprise? Well, this was a total cataract, very advanced cataract rather, and optical biometry was not possible. So my optometrist performed a contact ultrasound biometry. Obviously, that was messed up. So I was wiser from this experience, and subsequently, I have been using a very efficient and useful strategy while dealing with monocular hard cataracts. This strategy doesn't work for bilateral hard cataract. Now, this is the fellow eye, and the fellow eye needs to be pseudophakic or with very minimal lens changes. So I asked the optometrist to perform a careful optical biometry and ultrasound biometry, and there is good agreement between these two values. Then it is reasonable to assume that the optometric has used the proper technique, and whatever ultrasound biometry value I'm getting for the right eye, for the advanced cataract eye, is reliable. This is again confirmed by repeating the test once again, and this has done extremely well. And another thing I believe in is using the first eye prediction error to refine the refractive outcome of the second eye. So this works only when if we have a prediction error more than 0.5 diopter in the fellow eye. There has to be an interocular symmetry. Transcription errors in terms of IOL power, wrong IOL power, etc., have to be excluded, and there should not be an IOL malposition. So it was basically like this. Instead of using the entire refractive, the prediction error to adjust the power of the next eye for the fellow eye to be operated, for the Barrett Universal 2, an adjustment coefficient of 30% is applied. And for the traditional older formulas, a adjustment factor of 50%, a 0.5 is applied. So let me just explain. Supposing if we have a prediction error of +2 diopter in the first operated eye, so I would not be taking into account the entire +2 diopters, rather 50% of that if I use Harford-Key, Holiday 1, or the Circuit T. So my target refraction will be -1 diopter. And so that if I'm designing for a eventual plano outcome for this patient. So this strategy has helped me in many of my cases where there has not been desirable refractive outcome in the fellow eye. So friends, in conclusion, refractive surprise or problems associated with refractive surprise can be avoided by proper counseling, by proper management of the ocular surface status, ocular surface disease, perform keratometry on the virgin cornea, perform optical biometry, ensuring that all the validation criteria are employed, repeat the measurements whenever called for, use the newer formulas, Barrett Universal 2 or Hill RBF, which I routinely use, respect the contraindications for premium channel intraocular lenses. I use a fixed site for my clear corneal incision, 180 degree for the right eye and 30 degrees for the left eye, and use a centroid value. Ensure that there's a rexis overlap on the optic, and use a reliable, predictable intraocular lens. I'm sure with these guidelines, your incidence of refractive surprise will come down drastically, as it has happened in my own surgical experience. Thank you very much for your attention.
Thank you very much, Arup. That was excellent. I think in a nutshell, you have conveyed. Vasavada, sir?
Dr. Arup, what do you think basically went wrong in this case?
Sir, it was the ultrasound biometry was performed by my optometrist. It was a very advanced eye. Optical biometry, advanced cataracts, optical biometry could not be done. And the standard error, the axial length was underestimated and the myopic over.
What was the biometry of the other eye? Did you compare with the other eye?
The fellow eye was, -1 sphere and -1 cylinder.
No, biometry of the, whenever you are not able to do the optical biometry in
No, it was
the,
within normal range. It was within the standard
I
range.
mean-
It was not a short eye. It was not the extremes of axial length. It was within the normal range.
so what do you feel? I mean, did you see the anterior chamber depth? Because most of the time, whenever the optometrists are doing optometry, if the anterior chamber depth is less than the other eye, then maybe he has pressed the cornea a little more.
Yeah, it was messed up actually. Yeah, it could have been prevented by careful ultrasonic biometry, but it happened. That is the reason I got a surprise.
Because comparing the biometry of the other eye and particularly anterior chamber depth becomes very, very crucial. And anterior chamber depth can be found out by various other methods as well. So if there's too much of a difference between the biometry of the two eyes, we need to really look into the anterior chamber depth, which can vary. And of course, whether the biometry was done accidentally at the macular area or not, which can add another error into it. So why, I mean, what was the difficulty in doing the IOL exchange? Because the IOL comes out very easily and comfortably even after many years of surgery.
Yeah, so let me tell you, sir, what happened in this particular case. He was quite happy with the fellow eye. First I operated. Second, I had a huge spherical equivalent of almost 6.25 diopters. And he was an IFES candidate. He was an elderly man, small pupil. And it took me some time to convince him that, we will require definitely surgical procedure. Glasses were given as aniseconia, diplopia. He was not happy, so I had to undercorrect him. So it took him 17 months to come back to me for the, for the surgery. So by that time, the lens was slightly decentered, though it was stationary, and it would have been a difficult task for me to try to exchange the lens. So I thought Sulcoflex was a good option in this case.
So good surgery overall, excellent management. Any other?
Thank you
comments?
very much. Thank you, Arup. Actually, Sulcoflex is really a big savior when it comes to these situations, and it works extremely well. Little expensive, the Sulcoflex lens is, but it gives very desired results even with the toric Sulcoflex.
The cost of the lens actually depends upon the power that, -5 to +5, it is little less than the other powers. And then another advantage of the Sulcoflex lens, it comes with the, with the toric platform. So if you want to correct the cylinder, that also can be corrected by the secondary procedure.